All right, we're going to get started. So welcome everybody to the NNPBC Nurse Practitioner Practice Support Program Clinical Corner. I'm Patty Telford and I'll be the moderator today. And I'd just like to start by having a land acknowledgement to acknowledge that I am sitting today on the land of the Coast Salish people, the Musqueam, Squamish, and Tsleil-Waututh Nations. I am honored and privileged to be on this unceded territory today to be able to conduct our business, and just to recognize that NNPBC office also sits on the Silex Nation land. So just to hold your own lands with you today as we proceed. And just a couple of housekeeping things. I'm going to just a second here. I'm going to be moderating, and I'm very pleased to, excuse me, welcome Dr. Jim Wright. He is the former co-managing director of Therapeutic Initiative at UBC and the former editor-in-chief of the Therapeutics newsletter. He's professor emeritus in the departments of anesthesiology, pharmacology, and therapeutics in medicine at the University of British Columbia. Dr. Wright continues as the coordinating editor of the Cochrane Hypertension Review Group and still sees patients 1 day a week. He has spanned his education and experience across the country, obtaining his MD from University of Alberta, which is my alma mater, and his PhD in pharmacology from McGill, before settling on the West Coast. Jim's research focuses on appropriate use of prescription drugs, clinical trials, systemic review, and meta-analysis. Dr. Wright hikes, cycles, and plays tennis in his non-working hours, and he is currently spending the winters in Pasadena in California. So that's very exciting. And so welcome, Dr. Wright. I'm going to put the presentation up, and just so you know, people know, the chat is turned off. If you have questions, please put them into the chat, the Q&A box, and we'll monitor the questions from there. So I will put up your presentation.
Okay, thank you very much, Patty. Appreciate it.
Let me just.
Okay, so it's my pleasure to be able to talk about one of my favorite topics, and that is statins. And I'd like you to look at these questions and take a bit of time and answer them to the best of your ability. I will be giving you the correct answer to the questions at the end. And I'm going to be talking about the whole process of evidence-based medicine, and I'm going to be giving you what we presently know, the best available evidence in terms of the use of statins, both in people in general and then in people over 70. Okay, so if you could go to the first slide. So this is what we're talking about. You can probably go to the next one. So I don't have any conflicts of interest with relation to this. I'm actually semi-retired and no longer getting even money from the university. Next slide. And this just says what Patty has already said, that in terms of my present situation. Okay, and the next slide. And read this, because this is important. A lot of people, I would imagine, almost everybody is affected by statins. They are so widely prescribed. If you're not personally affected, I'm sure you have relatives that are affected by it. And I'm expecting there'll be lots of questions at the end, so please form your questions, and we'll have time to answer questions at the end. Next slide. Okay, so I'm going to give you a brief idea of how statins work, and then I'll give you the best available evidence for all ages. And I do this in a very concise form so that you can just really see what it is without huge amounts of numbers, etc. And I'll explain why I do that. And then I'll be talking about people over 70, and we'll be talking about what the benefit is in primary prevention and in secondary prevention, and a little bit about the harms. And then we'll talk about how, in what situations it's appropriate to deprescribe in people over 70. And then we'll conclude, and I'll give you the answers to those pretest questions. Okay, the next slide. So this is important not for you to try and figure out, but what's really important in terms of statins is that they don't just affect cholesterol. They are blocking an enzyme that's present in all cells, and that pathway leads to over 100 different compounds. And so when statins are working, they are reducing hundreds of compounds and not just cholesterol. And so it would be surprising if they didn't do other things besides lower cholesterol. And it's also it wouldn't be surprising if their beneficial and harmful effects are not related to cholesterol. And I'll talk a little bit about that. But just remember that these are a complex. It's a complex mechanism, and so it's something that we should be, should make you feel not so happy to just take them without thinking. Next slide. Okay, so we're now going to start to look at the best available evidence, and this is all based on randomized controlled trials compared to placebo. Okay, and when we talk about secondary prevention, we're talking about people who've had a cardiovascular event, a myocardial infarction, or a stroke, or who have proven atherosclerotic vascular disease. So when we look at the best available evidence, we have many trials, and they all report this outcome, and the answer to the question is yes, they do. It's a small reduction. The relative risk of 0.93 means there's a 7% relative risk reduction in total mortality. And these trials were done over 5 years, and so the absolute risk reduction is 1.3%. And so if in my practice, I would have to treat 77 people over 5 years to prevent one death. It's extremely modest in terms of the magnitude of the effect. But it does tell us that in that population, the benefits of statins outweigh the harms. And so we're confident that in that setting, the benefits outweigh the harms, and it is worthwhile prescribing. And we don't want to just look at mortality. We want to look at total cardiovascular events. And the next slide. So does it reduce total cardiovascular serious adverse events? And these are all heart attacks, strokes, and peripheral vascular disease events. And the answer is yes. And this is, as I said, based on placebo-controlled trials. And in here now we see a relative risk of 0.77, which means it's a 23% reduction, relative reduction, and the absolute risk reduction is now larger at 4.4%. But it still means that I would need to treat 23 people in my clinic for 5 years for one person to benefit. And the other people wouldn't benefit, and there's no way of knowing who that person is going to be. But still, we consider that good enough evidence to recommend the use of statins in that setting. So that's one of the settings where we would recommend prescribing statins. So that's people who have had a heart attack or who have proven atherosclerotic vascular disease. Okay, the next slide. So then the question is, what about people who've never had an event? So that's the primary prevention population. So these are the people who might have risk factors. They might have high blood pressure. They might have diabetes. They might have other risk factors. You might think that they're high risk, but the reality is in the primary prevention populations, many trials, these are placebo-controlled trials, there is no proven reduction in mortality, so we don't know that the benefits outweigh the harms. So the relative risk there is 0.98, and you can see that the confidence intervals include 1, and so it's not statistically significant, and there's not even a tendency to a reduction in mortality. And the next slide. So do they reduce total cardiovascular serious adverse events in primary prevention? And the answer is yes. You can see the relative risk is 0.79, statistically significant. But the absolute risk reduction is small, 1.4%. And these trials were over 5 years. So in that setting, I would have to treat 71 people over 5 years to prevent one event. And then the question is, are there any harms? And so the way we would look at harms is to look at total serious adverse events, and that would include the cardiovascular serious adverse events plus other serious adverse events. And the next slide. And total serious adverse events in people for primary prevention, statins do not reduce it. So they reduce cardiovascular serious adverse events, but they must be increasing other serious adverse events. And you can see that there's no reduction. So in this setting, the benefits do not outweigh the harms. And we have been promoting that we should not be using statins for primary prevention in any population. And we said this in our therapeutics letters some years ago, and we haven't changed, and the evidence hasn't changed to say that. So that to us that is clear. And so if you have not had a heart attack or a stroke, then the benefits don't outweigh the harms for the use of statins. They are widely prescribed in that setting, but and you might have questions, but I'd be happy to answer those going on forward. Okay, so let's go on. So how do we find out the evidence for people over 70? Next, click. There's was a major publication in 2019. It's the Cholesterol Treatment Trialists Collaboration. They control all of the data. And so you can see that there's lots of trials, 28 randomized controlled trials, and they have the individual participant data from those trials. And the next slide. Their conclusion is that statins produce significant reductions in major vascular events, irrespective of age. And they're saying irrespective of age or whether they are primary or secondary. And all they do is they just add this little bit at the end. There's less direct evidence among patients older than 75 who do not already have evidence of occlusive vascular disease. I'm going to show you why we don't believe that what they're promoting from this trial. But they have all of this data, and we don't personally have this data, so we have to do what best we can from what they do present. The next slide. So the problems with this analysis are that they have adjusted all of the data to 1 millimole per liter reduction in LDL. And that's based on the assumption that what the effect of cholesterol or the effect of statins is due to reduction in LDL. And we don't know that for sure. And this is just an example of what this does. When you, the real data from the ALLHAT trial was a relative risk of 0.91. When you adjust it to 1 millimole reduction per liter reduction in LDL, it magnifies that to 0.83, which is not a real effect. And so we think that this is entirely inappropriate, and that Lancet should not have allowed them to publish the data in this way. Next slide. So this assumption that reduction in LDL with statins predicts the reduction in cardiovascular events, and we're talking about major vascular events here, and that's what they talk about in this publication. Major vascular events include all of the cardiovascular serious adverse events, but they also include revascularizations. And revascularizations are when you go in and you get a coronary bypass or you get an angioplasty. So, but those are not the same as a major vascular event, and they don't have the same significance too. So we don't think that they should be included, but that's the way they've done this. In this large trial, it's the largest statin trial, and people were randomized to 40 milligrams of simvastatin or placebo. They actually tested this question. Does the reduction in LDL, is it associated with a reduction in major vascular events? And so you can see that when they've divided it into tertiles here, the people who had the least reduction in LDL had a relative risk of major vascular events of 0.78. The people who had the intermediate reduction in LDL had a major risk of, or a relative risk of 0.80, and the people who had the most had a relative risk of 0.79. So the reduction in LDL had no effect on the reduction in major vascular events. And from this, I believe, and I think I will be shown to be right ultimately, that the benefit of statins has nothing to do with the reduction in LDL cholesterol or total cholesterol. So they obviously should not be adjusting their data to a reduction in LDL cholesterol. The next slide. And there's difficult other problems with this. They don't give you the numbers so that you can analyze it independently. As I said, they use major vascular events, which includes revascularizations. You'll see that they don't give the mortality data separately for primary or secondary groups. And we would love to have the data so that we could analyze it independently. And we've requested it from this group, but they won't provide it. Other people have requested it as well, and they won't give up the data. So that also gives us a reason to be somewhat skeptical. Next slide. Okay, so this is the data they have, and I'm just showing you this, that there's quite a few people, 27,000 in the age range 70 to 75, and almost 14.5 thousand in people over 75, there was a preponderance of males, and more than half had vascular disease. So more than half were secondary prevention. Okay, so now we want to ask, does this data show that statins reduce mortality? And what this shows you is that the way they present it, there isn't evidence that either in the 70 to 75 group or the greater than 75 group that statins reduce mortality. The middle row is the per millimole reduction in LDL. They don't separate it into primary or secondary prevention, but they basically show that they don't have evidence that it reduces mortality. And what I've done is I've come up with what I think is the best estimate of unadjusted effect, and you can see that the unadjusted estimate is showing even less of a effect, less than, so it's going from 0.96 to 0.98 and 0.93 to 0.95. So again, but confirming that there is no evidence for having people survive longer in over 70 age group. Next slide. So does it reduce major vascular events for primary prevention? Again, all of these estimates, the 95% confidence intervals include 1, so there is no statistically significant reduction even in their adjusted data. But the column on the right is the best estimate of what the real data shows. And so that is showing no statistically significant, so no proven reduction in major vascular events for people for primary prevention. And the next slide. For secondary prevention, there is a statistically significant reduction in the way they present it. For when we correctly do an unadjusted estimate, you can see that there is a reduction in the 70 to 75 group and not a significant reduction in the over 75 group, but there is, it does appear that there is some benefit for secondary prevention with statins in this age group. So the question you should be asking is, well, how does that, what does that look like in terms of absolute risk reduction? And the next slide. And our best estimate of the absolute risk reduction is an absolute risk reduction of 3% for secondary prevention in people over 70. So what you should remember now, these are major vascular events. That includes revascularizations. If we corrected this to just serious cardiovascular serious adverse events, it would be about 2%. And you remember that the data I showed you at the beginning for all age groups, it was 4.4%. So what this is showing you is that that any benefit that is occurring is smaller in older people and not larger. And most people would have thought, oh, well, they're at higher risk, so it should be larger. But the data actually is showing that it's smaller. Next slide. If you want to learn about the harms of statins, I'm not going to get into them here. We published this letter. It's letter number 89, and you can read it. There are significant harms, and I think there are harms that we still haven't don't completely understand. But they are not completely safe drugs, and it looks like it's possible that over the long term harms accumulate in people. And the next slide. So the interpretation is that for people over 70, statins have not been shown to reduce mortality. So we don't know whether they do or not, but so far we don't. With all of the available data, we haven't proven that. Secondly, in people over 70 with no occlusive vascular disease, so that's primary prevention, they have not been shown to reduce major vascular events. In people over 70 with occlusive vascular disease, they do reduce major vascular events, but the magnitude is small. And the next, I think, so if what I showed you was that total cardiovascular events are reduced in adults by 4.4%. In people over 70, it's approximately 2%. So what that tells you that even for secondary prevention, it's only, you'd have to treat 50 people for 5 years to prevent one event. So it's not a huge benefit. And so if a person is having problems with the drug, you shouldn't feel too badly about stopping it. Next slide. Okay, so this is just a bit of practical information for you. So people where stopping statin is obvious, if they have a limited life expectancy, it doesn't make sense to be keeping them on a statin where the benefits are relatively small. And there have been trials now in people with limited life expectancy where the people were randomized to stopping the statin or continuing the statin. And in those trials, the people who stopped the statin did modestly better than the people who continued the statin. So there's even evidence that it's a good thing to stop the statin. And just in people with dementia, it's not appropriate to have them on statins, et cetera. And the next slide. So not starting or stopping the statin is advisable. So anybody with no history of occlusive vascular disease, there really isn't. We don't have evidence that statins are beneficial. And just remember that blood cholesterol or LDL is irrelevant. That doesn't tell you whether they should be started or they should be treated or not. And the next slide. So where you would be potentially advisable to continue or start a statin is people with a history of occlusive vascular disease, secondary prevention. But appreciate that the number needed to treat is quite large. And when we're dealing with patients, we should be giving them this information. And so if you explain this to a patient, many people, in my experience, when they're told that the magnitude of the benefit is so small, they would say, well, why would I bother to take a drug every day for that small a benefit? Okay, and the next slide. So importantly, there are 2 trials that are being done to try and answer this question. So these are people with primary prevention, and they're people, older people over 70, and they're being randomized to statin or placebo, and they are long-term trials. And we should find out from these trials over the next 2 or 3 years what the answer is for primary prevention. But one thing I'm relatively confident is that if there is a benefit in these people, it's going to be a small benefit because we already know that there's a very small benefit even for secondary prevention. So when these trials are published, then we'll have more data. And the next slide. Okay, so here's the answers to your pretest questions. It's not important to measure cholesterol, and cholesterol does not tell you whether or not you should be taking the statin. So that's false. And then the absolute benefit of statins in reducing does not increase as you get older. In fact, the evidence shows that it significantly decreases as you get older. Okay, so I'm available to answer questions, and I look forward to.
All right, thanks so much, Dr. Wright. That was amazing. I'm a former cardiac nurse and found that very interesting. There's a couple of questions. Andrea is asking, when and/or is there an indication to initiate a statin over age 70 for dyslipidemia?
So what? Yeah, I didn't show the data, but there is observational data that in people over 70, the higher your cholesterol, the longer you live. There is so in reality, you should not. That would suggest that if we lower cholesterol in people over 70, we could be shortening their life. So I would say that we should not be measuring cholesterol in people over 70, and we should not be prescribing statins based on their cholesterol level. If they've lived to that age and they have a high cholesterol, then that's just telling you that that's a good thing for them, and they're doing well. Yeah.
All right, the next question is, what about a patient who's diabetic? I thought recommendation is for a statin, even though it is a primary prevention.
I know that that message is out there, but in my opinion, diabetics who have not had a cardiovascular event are still primary prevention, and they should be treated with the same approach in that the benefits do not outweigh the harms for primary prevention. And remember that statins do cause diabetes in a small percentage of people. So you're actually treating somebody with a drug that increases blood sugar to a small degree. So it's not. I think diabetics should be looked at in the same way as non-diabetics in terms of that.
Great. The next question is, how long should a patient be on a statin? If they were started in their 40s for secondary prevention, is it for life?
That's a very tough question, and I've had lots of patients in my practice where that's the case. I think if they were started for an appropriate indication, they're still on it, they're not having any problems, I wouldn't change anything. I would continue it. But if there was any reason that they were having potentially side effects, their intolerance, I wouldn't hesitate to stop it, because we don't really have proof that it's still that they're benefiting in that setting. And if they develop dementia, again, I think it would be entirely appropriate to stop it and not be continuing the drug in that case. Yeah.
Okay, next question. Are there any risks associated with deprescribing in patients who are treated for primary prevention over 70 or below?
No, and I mentioned that there have been some trials where people were randomized to stopping or starting or continuing, right? So, and it's good that we have those trials, because some people thought, well, if you stop it, people might develop, it might precipitate a heart attack, etc. So in those trials, there was no evidence that people had adverse events from stopping. And over the longer term, they did slightly better than the people who continued the statin. So there is, and we need more trials like that, because it could be that when there's enough trials done, it might show that there is a significant benefit to stopping.
Yeah, the next question is kind of a bit of the same. Said, would you discontinue a statin in a healthy elderly person who's already on one? And I think you've answered that.
Yeah.
Do you think this advice could result in increased testing, stress testing, MIBIs, to determine if occlusive disease in persons with hyperlipidemia to help guide the decision making?
Well, I wouldn't recommend that. I don't recommend stress testing, or because I do think that if there's a reason for it, if people have symptoms, and if there's a rationale for doing, but for screening, testing, stress testing, or MIBIs are not a good idea, because you're potentially identifying people where the test is not definitive, and then that goes on to further things, and they end up with an angiogram, and then they end up with potentially a procedure or a complication, etc. So I do not. I think it's inappropriate to do screening testing for people who are healthy.
And do you recommend any supplements for those who are started on a statin, vitamin D, coenzyme Q10, or ubiquinol?
No, I don't. And there have been a small number of trials showing that coenzyme Q10 does not prevent adverse effects from statins. It's unfortunate. I mean, we thought maybe that would be possible, but it hasn't proven to be the case. And also vitamin D hasn't been shown to have any beneficial effects in that.
Someone's asking if the slides will be posted after the presentation. The recording will be available likely early next week on the NNPBC website in the NP portal under under primary care network resources under clinical links. So do you advise not to use Framingham for CVD risk then?
Yeah, I'm not in favor of doing risk assessments. They have not been studied in randomized controlled trials, and I do think that there's a risk of making somebody who's healthy sick by telling them that they have a high risk. So they haven't been shown to be beneficial, and it's an intervention in itself. And there are other things too. The different risk assessment tools give you different results, and there's a lot of reasons why risk assessment is not good. It's good for drug companies, but it's not good for patients.
All right, well, that's all our questions. I just want to again thank Dr. Wright for spending the time with us this morning. We really appreciate it. It was an awesome presentation. And if you want to follow more information with therapeutic initiatives, you can find them at www.ti.ubc.ca and also on Twitter at drug_evidence. And I've been to the website, and there's a ton of great information for all practitioners. So thank you again, Dr. Wright. And on behalf of NNPBC and the NP Practice Support Program, happy holidays. And thank you for joining us this morning.
Okay, thank you. I hope I haven't caused too much cognitive dissonance for people. Yeah. But I don't take any drugs myself, and I think that's the best thing for most people.
All right. Thanks, everyone.